Good evening, everyone. Welcome to the master classes in critical care medicine from Yashoda Hospital in collaboration with ISCCM Hyderabad. Today's topic for discussion is toxidromes and OP poisoning case. We have senior examiners Dr. Babu Abraham from Apollo Hospitals, Chennai, and Dr. Srinivas Jakkinaboina, senior consultant, associate professor, head of the department from MNR Medical College. So, and the case will be presented by Dr. Venkata Raman and Dr. Sitha Lakshmi from KIMS Hospital. Dr. Ramana, you can start your case presentation.
Dr. Venkata Ramana. Dr. Venkat, you can start the presentation.
Dr. Sitha garu kuda unnara?
Unnanu sir.
Yeah.
Good evening.
Good evening.
Sir.
Venkat garu may start cheyandi.
Okay, sir. Sir, I am audible, sir, to everyone?
Yep.
Yes.
Yeah, you are audible.
Yes.
Hello?
Yes.
Dr. Venkata Ramana, can you switch on your camera? Sitha Lakshmi, please switch on your camera.
Sir, a bit network problem, sir.
So, do you want to present? Who want to present?
Ramana sir is presenting, sir.
So, is Dr. Ramana around? Ramana, please present.
Dr. Ramana, you are not audible.
You have muted yourself.
Now I am audible, sir?
Yes.
Sir, can I proceed with the case presentation, sir?
Yes.
Yeah, go ahead.
Yeah.
Go ahead.
Sir, can someone share a screen, sir, so that because I think in my tab...
It's already shared, sir. It is
yeah,
visible.
okay, sir. Yeah, okay. Thank you, sir. Sir, good evening, everyone, sir. Myself, Dr. Venkata Ramana. I'm a DNB resident in KIMS Hospital, Sangareddy. And today I'm presenting a case of a 40-year-old policeman was brought to emergency department around 8 p.m. on 14th April 2022 by his neighbor with a history that he was found semi-conscious at his house around 7 p.m. With vomiters, urine and feces around him. This is a presentation to the hospital, sir. And
Dr. Venkata Ramana.
Sir.
So please go to what do you think your differential diagnosis a patient if you find like this in emergency?
Sir, the main presentation was semi-conscious, maybe altered sensorium with vomiters, urine and feces around him. So any patient with altered sensorium or any decreased sensorium, initially we have to think about any hypoglycemia or any drug overdose.
Okay.
And
So Dr. Venkata Ramana, just to continue, take up from there, like he is he is found semi-conscious.
yes,
He
sir.
has vomiters, urine, and feces around him. When you
Yes.
hear this history, what is the first thing that will strike your mind? What? Sorry?
Seizures.
Okay.
Excellent. Yeah. So it is
Yes,
seizures.
Yes,
So
seizures.
what you said is correct. Hypoglycemia can cause seizures.
Yes.
Some
Any
drugs can
substance
cause
abuse.
seizures. So you,
Yes,
in
sir.
your mind, DD of conditions that can cause seizures should go through. Okay, so don't stop with just drug and hypoglycemia. Then examiners will
please.
keep asking you what else, what else.
Okay, sir. Okay, sir.
Okay, so as I said, classically, this is a history of sounds like seizures. That's what we need to now.
So, yes, sir.
probe
Yes,
more.
sir. Yes, sir.
Okay,
Yes, sir.
very good. Okay.
So hypoglycemia, seizures you mentioned. Dr. Sita,
And,
you also can answer.
Yes, sir.
Yeah,
And,
please. What
First, we should rule out any intracranial pathology, sir, like semi-conscious intracranial
Okay.
pathologies, any leading to any this. If there is like intracranial nothing, then it can be other metabolic encephalopathies like hypoglycemia, any other metabolic parameters deviance, toxin ingestions, hypoglycemias,
hyponatremia, maybe sometimes causing seizures.
Yeah. So it can be multiple things.
Multiple
Babu sir was mentioning that it can be hypoglycemia, hyponatremia, it can be stroke,
yes,
tumors. Okay, a patient can be in shock, or toxicities like benzodiazepines or OP poisoning.
OP poisoning, yes.
And patient can have with alcohol intoxication also can present like this. Or suppose the patient has an MI and shock. Okay, sepsis, meningoencephalitis, CSVT, and any other failures like renal failure, liver failure. Okay, encephalopathy. So there are multiple reasons why this patient presents with this. Sir, can you add anything or
no, nothing. You have covered almost everything. So only thing is you go systematically. You know that it sounds like a seizure. So what are the conditions that can cause seizure? Go from head to toe, like what you can start with conditions affecting the brain and working your way down, to other metabolic and whatever you think of in a systematic way. If you go, you'll cover practically most of the things. That's okay. Carry on, Dr. Venkat.
Sir, upon receival primary survey, on airway examination, there were copious secretions were present, and breathing is rapid, shallow, and with SpO2 of 90% with 8 to 10 liters of oxygen, and there were bilateral crepitations were present, and his heart rate was 46 beats per minute, and BP was 110 by 100 mm/Hg, and all the peripheral pulses were felt. And his presentation GCS was E2, V3, M4, and peoples are bilaterally pinpoint. And the blood sugar GRBS was 200 mg per deciliter. And there were drooling of saliva from mouth. There is a pungent smell around him, and undergarments are soiled with urine and feces. This is the primary survey examination.
Dr. Venkata Ramana, now can you narrow down your differential diagnosis from your primary survey? What do you narrow down your differential diagnosis? What is your working diagnosis now?
Yes, sir. Here there are a few points like copious secretions and low saturation, bradycardia, and low GCS, pinpoint pupils, and urination and defecation and urination. All these suggesting maybe going at toxidrome towards any cholinergic crisis kind of symptoms, sir. Maybe possibility of organophosphate poisoning, maybe. Organophosphate poisoning possibility is high, sir, maybe.
So a patient can have bilateral crepitations, saturation, decreased saturation, heart rate 46 in any drug overdose?
Opioid compounds. Hypoventilation will be there, sir. In that also brady.
Brady. Okay. Any other drugs like beta blockers?
Yes, sir. Beta blockers.
Beta blockers can cause. Yes, sir. But usually, yes, sir.
Sorry. What are the points against beta blockers here?
Usually they will have hypotension and the pulses will be very feeble or absent, maybe.
Okay, and can they have a copious secretion?
No, sir, because as sympathinolytic, so usually there will be very much of dry.
So when you have to qualify that statement, Dr. Venkata Ramana, because when you say copious secretions, beta blocker can cause cardiogenic pulmonary edema, isn't it? that can
Yes, sir.
present
Yes, sir.
like copious secret, but might not have drooling of saliva, all
Yes,
that.
sir.
Okay, so be careful when you say no. Beta blockers can cause
Okay.
bradycardia.
Okay. Yes, but it's been more of lower respiratory secretions coming out of the mouth, not as a maybe you're saying. Okay, sir. I understood.
Okay, but how
Right,
will
sir.
the pupils be?
People will be normal, like
Correct.
normal.
So what
Pupils
other
will be-
conditions can cause this pinpoint pupils?
Opioid poisoning, pontine hemorrhages, OP
Okay,
compound
pontine
poisoning,
hemorrhage, opioid poisoning. Okay, anything else?
OP compound poisoning,
or organophosphate poisoning.
Okay, anything else? Something very common. What will alcohol intoxication cause? How will the pupils be in alcohol intoxication? Mydriasis or meiosis?
sedatus, normal sedatus.
Don't know, sir.
No, it will be small. It will not be pinpoint. Pupils will not be dilated. It will be constricted in alcohol too. Okay, but it will not be pinpoint.
In
Okay.
benzodiazepines, barbiturates, and alcohol toxicity, usually it can be anything. Like
Yeah,
sometimes
can be anything,
it
but
can
it
be
is
mydriasis or meiosis.
very unlikely to be
Dilated. So
yeah.
it is not pinpoint, but is
Okay.
a
So we have now brought down our differential diagnosis to most probably something which is causing
Predominant cholinergic symptoms.
coronary symptom. Now, I do not know whether the history was given. Now, if this person has a history of long-standing illness for which he's taking some drug, can any other drug cause this sort of symptoms?
Like neostigmine, pyridostigmine.
Correct. So
Mm.
anyone who is
Especially
on exactly.
myasthenia
Okay.
gravis patients, maybe overdose, maybe. Yes.
So correct. So a cholinergic crisis from physostigmine overdose also can cause the same sort of thing. Okay, don't forget that. Okay.
Yes. Okay.
So can he do he has any psychiatric disorder? He's on any medications? Because
Sir?
that he's on any medications.
Sir, he's only
Known case of depression, sir, but medications we don't know, sir. Like what he's using, he was brought by the neighbor, sir.
Okay.
Even when
Right.
attenders came, also we asked. They told like they don't know. Only he personally knows. They were telling.
So
I thought somewhere in the slide I saw that he's on antidepressants.
Yes, sir. Antidepressants he's taking. They told sir some for depression, but what medications exactly they don't know, sir.
What is the most common antidepressant toxicity that you normally see?
Right.
like
Correct. Loud, doctor.
TCA toxicity, sir.
Okay. So does this guy have a TCA toxicity?
no, sir. It is completely opposite symptoms. Sir. TCS will cause
Very
of
good.
more of
Cardiovascular,
anticholinergic symptoms, sir, because they have an
Correct.
anticholinergic property.
anticholinergic.
Yeah. Okay. Pupils also mydriasis. Yeah, as you mentioned, that is exactly opposite symptoms. So, can you suppose I want to check the toxic levels?
Okay.
What are the toxic levels you can send?
In these patients, maybe red cell cholesterol.
In general, what toxicologies you can send?
In general, we collect sample. We'll take an extra bottle for serum evaluation for alcoholic and drug levels,
Okay.
and
Alcohol
urine
levels.
urine like benzodiazepines, opioids levels, and urine samples for toxicology screening.
Okay.
And even will store feces for maybe, but usually they don't do feces. Feces maybe can collected and can send for evaluation.
Can you do any other levels, drug levels? Toxicity.
And toxicity like alcohol, opioids, benzodiazepines.
You
and,
can do acetaminophen.
Nomogram.
Acetaminophen levels you can do.
Acetaminophen or
And also
salicylate
they can-
levels.
Yeah, you can also do a digoxin levels.
Because,
Okay, it also can cause toxicity. Okay, ethanol, methanol. Okay, the organophosphorus, basically you do other tests.
that's it. Yes, sir, because there is no serological
And
test
also you
diagnosed
can
or
do
not.
phenytoin and theophylline levels also.
Yes, sir.
So
Okay.
these are all the common drugs where you do a Toxic levels
for
in
the
the
screening.
in
Okay.
the blood. Along with urine, already you have mentioned.
Okay. Okay.
Yeah. Sir, Babu sir?
Yeah, no, carry on. Carry on.
Yeah.
Next slide.
Yes, please.
Sir, we taken an ABC on arrival. It was showing a pH of 7.25, PaCO2 was 65, PO2 134. So it is more of diagnosis. It's a more of looking like a respiratory acidosis with hypercarbia, sir.
Is that so?
With even
I'll stop you here, doctor. I like to stop you here.
Metabolic acidosis also.
Sorry?
With existing, because bicarbonate is also low, metabolic acidosis community is also
Correct.
there,
So
sir.
you
Like,
can't say it is. You can't say it is
mixed,
only. If you,
it's more of mixed acidosis, sir. Yes.
okay. So there is some 4 negative base excess. You have to
Yes, sir.
account for that.
Yes, sir.
So with this ABG, will you will you reconsider your differential diagnosis? If you see this ABG and you have got your patient in front of you, what is the thought process that you will have? Does
Might be
OPC
there.
poisoning?
OP component
Yes,
of
sir. Yes, sir.
respiratory
OPC
depression.
poisoning can cause direct because there are direct CNS toxicity causing respiratory suppression can cause type 2 respiratory failure, sir.
Okay.
Or else, as such, because of severe bronchospasm or bronchoria causing type 2 respiratory failure with maybe any, but because his BP is okay, so maybe the likely toxic effect causing maybe metabolic acidosis, sir. Maybe as a such.
Now, usually, let me ask you a question. Usually, people who take OPC, how do they take it?
Well, here there are most we'll see the oral intake, sir. Other routes,
Correct.
sir.
No, I'm asking about
inhalation.
oral intake. When someone is taking OPC through oral route, normally what is the history you get? How do they take it? They take it directly from the pesticide bottle?
No, sir.
Mixed.
So sometimes they mix with water, sometimes they mix with Coke, or like thumbs up or Coke,
Yes.
like this. Or
Can they mix with
or
something
some-
else?
Milk.
Alcohol here is given answer.
Alcohol, yeah, maybe
But-
interfere with alcohol, sir.
Okay.
Okay.
Okay. So, do you think this ABG can suggest an alcohol?
But maybe acidosis
How will
part
you-
may be
how will you
contributed by
rule out?
alcohol part.
How will you rule out? You got this ABG. What is the next process to rule out whether you got alcohol or not?
Osmolar.
Osmolar gap. Maybe.
Osmolar.
You
Or
want-
else we will compare both the serum and osmolar gap, osmolarity, so that if it is more than 10, maybe you can increasing osmolar gap may suggest maybe any ingestion of other alcohols or maybe alcohol.
Okay. So let's say you do it and the osmolar gap is increased, but the anion gap is normal.
Okay, maybe is that isopropyl alcohol or acetone? These are the alcohols which even normal anion gap will be there.
Okay.
Among
All the
alcohols,
okay. All the
remaining
other
they have
alcohols.
ion
Okay,
ion
good.
gap. Sir.
Good. I just wanted to know whether you are aware of that. Okay, fine. So here you have mainly a respiratory component. It's a mixed but a large respiratory component, but also a metabolic component. So don't just think that it's only organophosphorus. Keep looking for others also. Okay.
Okay. Done. Okay.
Fine.
Yeah, Dr. Venkata Raman. So, do you think this ABG is validated?
I didn't want to.
Because the validation will come from H plus ions 7.25 and
ET minus 20.
So, what is the formula? Can you tell? H plus is equal to?
H plus 24 into PaCO2 by bicarbs.
Yeah, just calculating while you are discussing. It is coming as 24 into 65 by 20 is approximately 78. H plus ions is 78.
80 minus
So-
25. 50.
78
Yeah.
every 10 increase point.
55.
So
55 is coming.
So 7.3 is equals to 50. 7.2 is equals to 60. Okay, now it has come as a 78. So it will be around
7.1 something, huh?
It should be around 7.1. So
Okay,
so you need to check, at least check daily once your ABG in your ICU, whether you need to again calibrate your machine or not. Okay, most important.
I understand. Yes.
Yeah, shall we go to the next slide, sir?
Yeah, go ahead, carry on.
And at this point of time, we intervened as because he was semi-conscious and there was a focus of secretion, saturation is low, so we intubated him and started on continuous ventilator support, and IV fluid was started at around 100 ml per hour, and thinking it of more of atropine, organophosphorus poisoning compound, we started giving atropine, and in the incremental doses, we started with 2 mg and with targeting heart rates of more than 100, and till atropination with targeting where lung should be dry and heart rate should be more than 100, and my checking for axilla and skin to become dry, and pupillary maybe it may be sometimes so late reaction, so dilated up to 4 mm on reacting to light. And later that, once atropination achieved, we started atropine infusion as a 2 mg per hour, and pyridoxine was given at 30 mg per kg bolus, followed by 500 mg per hour. We started infusion.
So can you tell the mechanism how this poison acts?
It acts mainly like anti-acetylcholine.
So we have firstly we have zero down to organophosphorus or carbonates. With these all symptoms.
Yes, sir. More
Yes,
of
fine.
going to the test organ.
Okay. Yeah.
And it is a anti-cholinesterase. It inhibits acetylcholinesterase enzyme, so that there is a more availability of acetylcholine at neuromuscular junction. So it acts like a continuous receptor activation by acetylcholine, causing all cholinergic symptoms.
Okay. So what is the? Can you give glycopyrrolate in this patient? What is the?
Yes,
do you have a study
yes,
on atropine versus glycopyrrolate?
We can give glycopyrrolate, sir, but it doesn't cross blood-brain barrier. Those patients who have a CNS symptoms, it can't revert those cholinergic symptoms. So better we prefer those who have CNS predominant symptoms and central and peripheral cholinergic crisis, we have to go for atropine. Maybe where only peripheral symptoms, maybe we can go with glycopyrrolate, but atropine has achieved atropination very faster than glycopyrrolate. So even in peripheral, in acute setting, maybe we have to go for atropine than glycopyrrolate.
Can you tell the evidence, any evidence-based atropine versus glycopyrrolate?
I have searched for these atropine versus glycopyrrolate, but there were no specific studies. I don't get, sir.
Yeah, just I will mention.
Sorry.
No, it's okay. I would like to mention two or three studies I've found. So, but very small number of group of patients where atropine versus glycopyrrolate, which was published in 2010 from I think Sri Lanka. They've taken only 33 patients total in the group, and they have randomized and saw, and they found that. But again, standardization is a difficulty in this group of patients. They found that length of stay, mortality, morbidity is same in both the groups. Okay, but CNS symptoms were higher in the atropine group, and the cost is high in the glycopyrrolate. This is published in 2010, and one more study published from India in 2000 in UAE, from UAE in 2018, UAE and Pakistan. So they found they have looked into 100 patients, and they found that out of 50 patients in atropine group, they found the mortality is 20%. But in the glycopyrrolate plus atropine they have used. They are not only glycopyrrolate. One group is atropine, one group is atropine plus glycopyrrolate. They found that the mortality rate is only 8%, and they have a decreased CNS effects. But it's a small group of study patients, and there is no standardization and in the baseline characteristics. I think at present we can think of as most of the patients have a CNS symptoms, we can start with atropine in this patient. Suppose the patient has a CAD or increased tachycardia, more tachycardia.
Tachycardia, they can't sustain. Okay.
And we are not achieving the targets, specifically secretions. We can add on a glycopyrrolate in this patient. The cost is going to be high.
Okay.
And what is the role of PAM today?
Sir, a role of PAM only there is a theoretical benefit that it reactivates acetylcholinesterase, but whatever the reviewed articles and observational studies and RCTs they were done, there are more against peroxime use, and initially they compared with higher dose versus low dose, where higher dose causing more of toxicity, so they came down to lower dose in the form of 2 grams initial bolus followed by 0.5 gram per hour, like infusion they were compared. In lower dose with moderate toxicity, it have a little bit of survival benefit, but other than that, whatever the studies they done, more of favoring there is a no benefit of giving products themselves. But in order to prevent aging or early presentation within 48 hours, maybe products and role there is a survival benefit, sir.
So initial, as you were mentioning, that initial studies which were from Mumbai, is a government hospital.
Pune.
They found that there is a high dose of PAM has a benefit, but WHO has standardized the dose. And later we had in 2005 and 14 there were few studies were published. Again, the numbers are smaller, and there is no difference in mortal ICU length of stay or ventilated duration in these patients and PAM with atropine. And here one of they have found that 6% mortality in PAM with atropine, and only in atropine there is 0% mortality. Numbers are very only 50. And one more study published in 2014 on 150 patients, atropine versus atropine with PAM. They found that there is an increased length of stay in PAM group. So the PAM now, I think again it differs from hospital to hospital and individual these units. So what do you do, sir, Babu sir? To continue with PAM?
Yeah. We use it in a different way, but yeah, I will discuss that.
Yes.
So, Dr. Venkat, I want to start from the beginning. Let's take the first sentence. Intubated the patient. Now,
Yes.
organophosphorus patients, when you intubate, can you tell me how you intubated them? What are the drugs you used, or what drugs you should not use?
Sir, in this patient, we have to avoid depolarizing muscle relaxant, sir, especially succinate choline, because they have a similar depolarizing action like the OP compound. So it will aggravate the muscle paralysis. So maybe you can go with a non-depolarizing muscle relaxants for intubation.
So which one would you use?
Usually we use rocuronium, sir, here.
And what dose will you use?
Rocuronium 50 mg, sir. 50 mg.
Don't give me that. 50 mg for a 100 kilo man, 50 mg for a 50 kilo lady.
0.6 ml.
Rocuronium dose. Are you an anesthetist?
Sir, I'm an emergency medicine, sir.
You're emergency medicine. Hey, emergency medicine, and you don't know the dose of rocuronium, I'll beat you.
0.9 mg per kg.
Okay, 1 milligrams per kg. Okay, easy way to remember. Okay, so in organophosphorus patients, what dose will you use? You think 1 milligram will be enough?
Because if because they are already because severe toxicity, they already have a muscle weakness. Maybe
no, they will not be paralyzed, especially acutely.
Yes,
they will
yes.
not be paralyzed.
Yes, sir.
So in organophosphorus poisoning patients, standard dose of non-depolarizing is enough. Usually.
Okay.
The other presenter?
Yes, sir. I think
What? Sorry, what dose did you use?
1 mg per kg only we use, sir.
Correct. So 1 mg, the problem with 1 mg, it might work. Patient may get paralyzed. If they don't get paralyzed, which are the conditions where you use higher dose? Do you use higher dose in patients? There are a certain group of patients where you might end up needing higher dose. Okay. So organophosphorus is one of them. Sorry?
Okay, sir. Okay.
Organophosphorus is one of them. I'm not saying that you should start with 2 milligrams per kilo and thing. Start with 1, but if your patient is not getting paralyzed, you might have to use a higher dose in OPC poisoning. Keep that at the back of your mind. Okay. So what will be the what is the difficulty you're going to anticipate when you intubate this patient?
There will be lots of copious secretions are there, sir.
Correct.
So
airway can be a difficult airway, isn't it? Because of the copious secretion. So keep that at the back of the mind. When you sedation, what would you use?
Sedation, maybe fentanyl or midazolam.
Okay. Propofol or either one of them, because remember that seizure. Okay, you're going to use benzodiazepines or propofol along with your paralytic agent. Okay, because this patient already had a seizure, isn't it?
Yes, sir. Possibility. Yes, sir. Because
possibility of
like
a seizure is that.
Yes.
So you're going to use either one of them. Okay. Now you started, after that you started on lung protective ventilation. That is okay. Started on IV fluids 100 ml per hour. Comment on that. Why did you start on IV fluid 100 ml per hour?
Because there will these patients have maybe they had a loss of urination, defecation, and sweating. There will be loss of excessive loss. There will be there. So maybe we had to initially we had to hydrate them.
Okay.
So that's why we'll give initial 500 to 1000 ml bolus. Then we'll start with according to urine output or plus extra 50 ml like that will give.
Okay, the initial part I agree. Just before you intubate, you want to make sure that there is no hypovolemia, which will precipitate a circulatory collapse, because that is one of the biggest problem when we intubate, isn't it? Circulatory collapse leading to cardiac arrest is the biggest risk when we intubating patient, especially in emergency. So I agree, you may give fluid boluses to tide over that, and then you intubate. Once you got it, then why do you need fluids? And how will you give fluids? Quickly, I know this is, I don't want to take the discussion outside the purview of what we need to do. What I want to know is, this is not a patient who is septic, hypovolemic, that you need to give a lot of fluids. It's a totally different case.
Maybe
so after the initial resuscitation,
urine output
only considering maintenance.
Urine output plus losses, sir, plus 50.
How are you going to assess the loss of, because he'll be, he's having bronchoria, diarrhea, all that, isn't it?
Yes.
So you should be able to assess his fluid status before blindly.
Fluid status, yes, sir. Yes, sir.
Okay, we won't go down. We won't go down in.
Yes. Yeah. We want to assess.
We won't go down that.
Okay.
Okay, we won't go down that path.
What about artificial?
We are diverging from the.
Did you start an artifice?
Sir, at this stage we didn't. We kept an NG tube, but we didn't start artifice, sir, as of now, because we are starting high doses of atropine where it can hamper the gastric motility. So maybe we'll wait for a while, and after settling everything, maybe after assessing bowel sounds, everything, then we can start. We'll start artifice in this patient.
Okay, doctor. The other thing, any poisoning or case, what is your approach? The first approach is the initial resuscitation. That's what you are doing, isn't it?
Yes, sir. In the airway breathing circulation, that part.
Correct. That's the initial resuscitation.
Yes,
what is the second step? In the general approach to. Yes.
In this patient, will mainly focus on decontamination, sir. And next day, antidote, sir. Along with maybe you can do.
So you have not mentioned that. You haven't mentioned that. That's what I'm saying. You have done the resuscitation. You have not mentioned about how do you decrease absorption of the drug. What was done? You have not mentioned. What did you do?
Okay, Okay. In these patients, we'll try to keep them in left lateral position, and
Why you want to keep
we
it in
try
left
to.
lateral position? You have intubated the patient already.
Okay. No, sir, because in the maybe we'll take out the clothes and we clean the skin and everything with water,
Okay.
and we'll give after placing NG tube, we go for gastric lavage and giving
Okay.
activated charcoal.
How much? After how much
Can
time?
we hold that? Can we hold? Yeah. Good. Yeah, no, that's what I wanted to know. Yeah, you're saying gastric lavage. What is the role of gastric lavage?
What is the role of gastric
within because in OP compound or in general poisoning, gastric lavage has a not but it is not harmful, so we can go with gastric lavage, sir. But there is no evidence suggesting that there is an advantage of gastric lavage. But because it is not harmful, so we can go ahead with gastric lavage. Presented within early 1 hour or 1-2 hours, sir. Because after that the gastric transit time will pass the contents from stomach to beyond the stomach.
If not intubated, can the gastric lavage harm the patient?
Sir?
Airway
Not
should be
intu-
protected, sir.
If not intubated, gastric lavage can harm the patient.
Yes, sir.
Yes, sir,
harm,
because
sir.
they are prone for aspiration risk, so maybe we have to be very cautious in this. If is always alert and very sound mind and is cooperating for keeping the NG tube, then we can go ahead with NG tube placement and we can go for gastric lavage. But what is the stomach full status and the sensor is already semi-conscious? In this patient, maybe without intubation, doing a gastric lavage is a harmful thing, sir, because they may have a aspiration risk.
Okay. Gastric lavage. Fine.
You
Okay.
mentioned also charcoal also here mentioned. What is its role? So ideally, this patient came after how much time?
In this patient, because he's already received gastric lavage outside hospital, sir, so we don't do gastric lavage for him. But because what is the exact time point, presentation to hospital, and when he was taken, we don't know. So that's why we don't do gastric lavage in this patient, sir.
So ideally, it is useful much in patients who has come within 1 hour. Or
Yes,
1.5
sir. Okay.
hours. Okay. Now beyond that, it is not much useful.
Okay.
So Dr. Srinivas did bring about activated charcoal. Is there a role for activated charcoal?
Sir, because especially organophosphate poisoning, activated charcoal has a limited role because it is very poorly absorbed to charcoal. Because it has more of non-polar bonds, it has more non-polar bonds, so it is less absorbed to charcoal. So it has a poor absorption with activated charcoal. So maybe in this case, it's not very useful. But where other poisons will have maybe a beneficial role.
Yeah, let's stick to this case. Yeah,
Yes,
let's stick to this case.
This case is have a minimal role, sir. Maybe it won't.
Okay. So this is decreasing absorption. Next is elimination. How can you eliminate organophosphorus?
Sir, these compounds are more of they are very rapidly distributed to fatty tissues, sir. So
how do you know that?
Hemoperfusions.
It is very lipid soluble compounds, sir.
Are all organophosphorus lipid soluble?
Dimethyl compounds. Dimethyl compounds are more lipid soluble, sir, than diethyl compounds.
Okay. Okay. Is that so? Is it that all dimethyl are lipid soluble and diethyl are not?
Most, sir, like long acting ones, like which have long off-life.
Okay, fine. So, okay, you may be correct. Okay, is there any other way of eliminating this thing? You told one. If it is by removing the clothes, giving a body wash, all that. If it is absorbed through the skin, if it is orally done elimination, then we have nothing much for organophosphorus, isn't it?
Yes, sir. Any like
Okay.
renal replacement therapies or extracorporeal techniques are not beneficial in this point, sir.
Sorry, I didn't hear you. What did you say?
Any renal initiating dialysis or hemofiltration,
No, no.
hemodiafiltration or extracorporeal techniques are not useful in this patient because
Correct.
only other
Okay.
option.
Yes.
Yeah, agreed. You are telling us what are the things available. I agreed. Okay, so it's not useful in here. I agree. Fine. Okay. The next step, atropine. You did talk about atropine. How does atropine help with organophosphorus?
It's mainly
What does it do?
it blocks the muscarinic effects of this OP compound poisoning, sir.
Okay. Only muscarinic?
Yes, sir. It's more of muscarinic effects on the and
More.
Okay.
Okay. So it mainly affects the muscarinic. Okay. Fine. So it. How does it do it?
Sir, atropine it blocks the it has a competitive agonist at the level of acetylcholine receptor, sir. So it will
competes with what?
It's the acetylcholine receptor, sir, at the level.
No, it competes with acetylcholine and for the receptor sites, isn't it?
Yes,
That's
yes,
how
sir,
it does
yes,
it.
sir, yes, sir.
Okay, fine. And it's mainly a muscarinic. So what happens to the nicotinic effects?
Nicotinic, sometimes they have a tachycardia and mydriasis components, because that's why maybe in targeting heart rates and people were not suggested during atropinization.
In higher dose. Okay, so okay, you said atropine crosses the blood-brain barrier, so it can be used for
So it even reverses the
CNS effects. What receptors are there in the CNS? Sorry?
Like
more of
what receptors are there?
Okay.
muscarinic, all
N
M1
type,
to
sir.
M5 all are present.
Okay, fine. That means in the CNS it acts on the nicotinic receptors, atropine, not muscarinic. Am I correct? It has muscarinic receptors?
Yes,
In
sir.
this-
M1 to M5.
More of muscular.
Tell me that again. Yeah, I'm getting two
CNS
messages.
No, sir. It also reverses muscarinic effects in the CNS only.
Yes. So in the CNS, both receptors are there, muscarinic and nicotinic.
Yes.
Okay. And atropine crosses the brain barrier, and that is why it is. So you have given the dose of atropine, everything that you have used. Fine. I think subsequently you have come down. Then you have used PAM. Okay. Now you used. How does PAM work? Palidoxime. How does that work?
Sir, Palidoxime acts by reactivation of acetylcholinesterase, sir, because the acetylcholinesterase has two sites. One is acetic site and anionic site. The OP compound binds to anionic site, and the Palidoxime binds to acetic site, and in that way, we try to reactivate the acetylcholinesterase enzyme by replacing organophosphate compound from acetylcholinesterase. So.
Okay.
So mainly reactivate the acetylcholinesterase enzyme. Okay.
So what you told me is right, and then you had discussed evidence for using of PAM. Okay. Now, if we are going to use PAM, which are the group of patients you'll use the PAM? Is there any specific type group of patients of OPC poisoning that you will use PAM?
Moderate toxic patients, sir. Maybe in
what do you mean moderate?
The amount of dose it's not specified, but those patients are now intubated and have a maybe okay. I don't know, sir. Really sorry.
Based on the severity, fine. Is there any other way that organophosphorus compounds has been classified by the WHO? based on its potency?
These are class. They being classified into WHO 1, 2, 3, and 4. 1 and 2, 3, sir.
Correct. 1, 2, 3. What is that?
Yes. Especially like phosphate compounds, fluorinated compounds, and
What is this 1, 2, 3? What is it based on?
based on LD 50.
Toxic moderately.
Sorry, tell me that,
LD,
doctor.
LD toxicity, LD 50, sir. Lethal dose.
Yeah, what is that? What is that?
So where the most of the 50% of the patients will die after taking this.
Patients. Patients. Is it
Animals.
patients?
Animals.
Correct.
Yes.
These are based on animal studies. They have classified organophosphorus into class 1, 2, and 3 based on the toxicity level
Yes, sir.
seen in animal models, isn't it? So it's called the WHO hazard classification. The most dangerous ones are class 1, followed by less class 2, class 3. So where do you think PAM is found to be more useful?
In this more of more of diethyl compounds and more of phosphorylated compounds. Phosphorylated.
Okay. Now you're going down another path. That's another classification. Diethyl and dimethyl is another classification. Okay. Now that you have mentioned that, let's talk about that. Why are you using it more in diethyl compound and not in dimethyl compound?
Aging.
Sir,
Someone said aging. What is aging?
once these OP compounds bind to this acetylcholinesterase enzyme, they kept losing alkyl groups. So these enzymes become irreversible to reactivate. That is called aging.
Okay. Fine. So what is the difference in aging between diethyl and dimethyl?
Diethyl compounds cause aging by adding phosphoryl groups, I think, sir. Sorry, sir, I don't know, sir. If I take the guess,
Aging occurs quick, like within 3 hours, sir.
Which one? Where?
Diethyl compound, sir. Dimethyl.
Sorry, tell me that again.
Diethyl, sir. It will take like 40 hours.
Yes, correct. About 30 to 40 hours. Yeah. Which one? Ethyl
compounds.
Methyl compound. Maybe.
Yeah, diethyl. So how is that going to help you in treating patients with PAM?
So time period.
Sorry?
Time period will decide, sir. Maybe if they come early and they have a role.
Compound aging has not happened. Still, we have the chance to reverse the acetylcholinesterase levels at the neuromuscular levels.
Okay. Can you, doctor, can you explain that a bit, because other participants are also listening? So I want them to have a clear idea, because what Dr. Srinivas and I are trying to tell you is PAM has got a very controversial role. Okay, so you have to be very clear when you start PAM that you are very clear about benefit. Okay, so PAM can cause harm. So you want to be very clear. I am starting PAM because this patient has this is criteria, and maybe he's in the small group that will get benefit. So that's what we are trying to. So doctor, can you repeat that once again? One group of patients that you're going to give PAM would be those who are taking
diethyl compound groups and patients who are moderate ingestion.
Okay. And
early presentation.
When you say early, how early?
Within 48 hours, sir.
Okay. Okay, 48 hours. And in hazard classification, group 1.
Group 1. Yes.
Okay, usually the group 1s are the ones which will come to you with the severe symptoms. Okay.
Yes.
Is that clear?
Yes, sir.
Yes, sir.
So that's what it is very important that you, in your history taking, you have to get the family people to go and get you the container of what they have taken. so that you know the name and then you look up with the WHO list to see which group they have. Because in India, we have got all the hazard group 1 pesticides still available. And in Sri Lanka, they had only hazard group 3. Okay, that's why if you see most of the PAM studies coming out of Sri Lanka shows PAM does not have any benefit. Okay, because all the pesticides are of hazard group 3, whereas in India we have got hazard group 1, and our studies which have come from Bhopal and other places have shown benefit. Maybe that is the difference. Okay. I mean, have I confused you all, or is it clear about it?
Yes, clear.
Okay, so I think you should go back and look up at this thing, which is the small group of patients in whom you will use PAM, and the PAM that you're going to use is in the WHO dose.
Okay.
The 30 milligram dose which you have given, and not in small dose. Small dose also has not shown. The studies from Vellore has clearly shown that small dose PAM does more harm than benefit. Okay, so this is what you need to know. Okay, sorry, I've taken some time on this slide because I thought we should spend. Dr. Srinivas, sorry, anything else you wanted to add?
No, actually, this is the most important thing in our discussion.
Okay, fine. Okay, carry on. Next.
And his past history, it doesn't have any co-marks, and surgical history is nothing. And he is a non-smoker and alcoholic. And from family, they given a history of he had a depression. He was using some antidepressants, but they are unable to procure the drugs, or so we don't know what the medication he is taking.
Fine.
And one general examination, second survey, and in general examination, is moderately built, nourished, and he was already intubated and sedated, and there is no pallor expressed sinuses, clubbing, or lymphadenopathy. Head and face examination is normal, and eyes, bilateral pupils are consistent, and there is no discharge. And ear, nose, and neck examination is normal. And little bit chest, there was a little bit of muscle fasciculations were present. And lungs, bilateral air entry equal, and scanty coarse crepitations was present on initial examination. And cardiac examination is normal, and bowel sounds at that point of time we are able to hear abdominal bowel sounds.
Carry on.
And post after intubation and after resuscitation, the heart rate is 130 beats per minute, and the respiratory rate we kept around 24 beats per minute, and the BP 130/90, and temperature is normal 98.7, and with FiO2 of 80 and PEEP 8, he was maintaining saturation of 100%, and the GRBS is 237. And ECG, more of it showing like sinus tachycardia with a little bit of STT depressions, maybe possibility because of tachycardia. And echo, we did echo is normal, sir. And so more of maybe rate related changes we are seeing, I think.
Can organophosphorus actually cause myocardial problem?
Because of bradycardia, maybe it will show hemodynamic effects, sir.
No, I'm not sure. I'm not sure. I just wanted to ask whether you have read anything. That's all. No? Okay, fine. Go ahead.
And the lab.
Anything significant? Anything significant in the labs?
In the only little bit of bilirubin was little bit elevated, sir. But otherwise, electrolytes and remaining metabolic panel looks okay. And the TLC were a little bit of 16,000 on initial basis. So
Okay.
maybe in this.
Yeah.
These patients
The
they tend
bilirubin.
to have a leukocytosis. And initial, maybe as of a toxic effect, maybe sometimes bilirubin, maybe cholestasis picture will be present, sir.
Is this bilirubin cholestatic?
It's not cholestatic, sir, but sorry, maybe because of toxic effects, sir.
Sorry, because of?
As such, toxic inflammation, maybe.
Now, if you look at it, total bilirubin is 2.58, which is borderline mildly raised, with a direct of 0.75, because it tells you indirect is more.
Indirect is more.
So, can organophosphorus cause hemolysis?
Yes.
Is there any
Don't know.
evidence?
No.
No.
Can you all look it up? Because I also don't know. Anyone knows? Srinivas, any?
I also don't have idea.
You also don't have, okay.
I don't think.
Fine.
We'll look it up, sir.
Yeah. So this is might be, or does he already have some sort of hemolysis
Maybe
going
also-
on under the
Maybe.
Sorry, tell me, doctor.
No, sir. I'm saying.
Yeah, okay, fine. Carry on. I
One of
can't
the
explain
one,
that.
One of the response has come, yes. So from the chat box one. Yeah.
What is
yes,
that?
please go. No, hemolysis. One of the chat box they have mentioned that yes.
Yes. Someone has said yes. Okay.
Yes,
If they
sir.
have seen,
Yeah.
yeah, okay.
Probably check.
I'm not sure. I haven't seen one. Okay, fine.
And albumin also is little lower in this 2.23.
Yeah.
And WBC is elevated. So I think these two are only the parameters which are deranged.
Correct.
Yes, sir. Yes.
Okay. Carry on, doctor.
And coagulation profile is normal, and we sent on 14th pseudocholesterol level. It came down to it came as 1987, sir, and reference lab value is 5,200 to 13,400. So it is almost.
Doctor, go back. I want you to comment on that pseudocholinesterase.
Sir, it is plasma cholesterol. It reflects plasma cholesterol level, sir, and in this, because of increased anticholesterol activity, it means it will get the values get low in these patients, OP compound patients.
How sensitive is it in diagnosis of OPC poisoning?
If it is low, means sir, exact value I don't know, sir, but it is highly, maybe if it is low with the background of OP compound, it is highly sensitive, sir.
Okay. Now, which is a more can you what I meant by my question is, can you can you
compared to RBC cholesterol level, pseudocholesterol level, RBC is more sensitive than cholesterol activity than pseudocholesterol level, sir.
Good.
First thing. And
but
RBC,
my question is, by looking at the level of pseudocholinesterase level of pseudocholinesterase, can you comment on the amount of OPC or the dose of OPC has taken? Does it correlate?
The percentage of decrease in cholesterol level can tell us the severity, sir, because at almost 1987, no less than 10%, 20 to 30%.
No, doctor. I think that's wrong information. I think that's wrong information. It's if it is RBC cholinesterase which you are measuring, which is difficult to measure and expensive, then it correlates with the severity. Whereas a pseudocholinesterase just tells you that the patient has been exposed to OPC. It does not tell you the severity or the amount the patient has. Can you use the pseudocholinesterase for titrating your PAM or atropine level?
No, sir, because it has a variable values with repeating check. On repeated checking, it shows a repeated because there is a lab variation. So we can't use this as a treatment response.
Okay, so correct. What you said is correct. So it cannot be used to measure the severity of OPC poisoning, nor can it be used for titrating your PAM therapy. Because it is not a direct, it does not fluctuate with the level of OPC in blood. Okay, that's what you need to understand. But it tells you whether the patient has taken an OPC compound or not. It tells you. Okay, that's all it tells you. Okay, go ahead.
On day 2, patient ventilated settings were he was on a 50% FiO2, PEEP still 8, and PF ratio was 232. And PSCO was 32, and still there are scanty crepitations were present, and we continued on sedation on day 2 also. Heart rate is 105, and BP is 127 mmHg, and the temperature is normal. And in this day, it was a little bit drowsy but arousable. People's around 3.5 mm bilaterally reacting, and even occasionally obeying commands. And same lung pulmonary ventilation we continued, and atropine infusion and PAM infusion we continued. And on this day, we started RT feeds, and we started a little bit of low dose thromboprophylaxis for him.
What do you mean low dose thromboprophylaxis?
Like thromboprophylaxis, sir, sorry.
Okay. No, I don't
Prophylaxis
know.
dose we started. No,
Yeah.
sir.
Okay.
Prophylaxis dose we started, sir.
Yeah.
Okay.
And on day 4,
any antibiotic was started?
sir, on initially we'd given like Morosef 2-gram dose, sir, but after that we didn't give any antibiotics.
Good man.
On day
Yeah, carry
4, around 5 p.m., a patient became irritable and the heart rate became 150 and the temperature around 104. And he was on atropine infusion, so we checked bowel sounds were very sluggish. So we thought maybe possibility of atropine toxicity because we had a continuous atropine infusion. So we stopped atropine infusion for 1 hour, and after we reviewing when our heart rate 80 to 90 and temperature 99, atropine infusion started again around 1.6 mg per hour, and lung protective ventilation and atropine infusion we continued. On day 3, pseudocholinesterase level came around 5,000 units per liter.
Yeah, almost like pseudocholinesterase levels has become normalized.
Almost
Looks like you were well.
increasing towards normal trend.
Yeah. So do you think this is heart rate is high 150 and temperature is 104 because of atropine?
Sir, because he doesn't he doesn't have any there is a reason for maybe because he doesn't have any signs of hypotension or any hypoxia. There is no other reason. We search for other whatever cause for tachycardia, sir, but there is no cause we are able to find out. Maybe temperature, because of temperature, because 104 that sometimes can cause tachycardia. And
So
these two.
So atropine will have tachycardia of 104. I can put in another way, because of high temperature, the patient has a tachycardia 150.
But it was an atropine infusion. It itself can cause anticholinergic effects, can causing hyperthermia,
but
tachycardia.
Do you see 104? Such a high temperature?
Because they tend to cause, sir, because they mention like high.
Every 1 degree centigrade, 10 beats increase.
So, so what did you do for the? So, without giving any paracetamol, the temperature has decreased to 99. Yeah.
He stopped. They stopped the atropine.
So immediately it has come down.
No, sir. We stopped the infusion and we sponged him. And after that, around he took almost 1.5 or 2 hours. Sir. After that, he settled, sir, actually.
Can you tell me here in this patient now? Can you tell what is the WBC count, what is the blood pressure, what is the urine output in this patient, and X-ray findings in this patient? Because the patient is on a day 4. Now I'm seeing the spiking of temperature in our ICUs on day 4. We suspect some bugs. And
yes, sir. But his counts on day 4 are still around 12,000, sir, because we didn't mention because around 12,000. And the X-ray, initial X-ray, there were bilateral mediastinal heaviness was there, sir. And so initially we thought because of maybe cholinergic crisis, maybe because echo was good, and on that day there was no fever, and maybe it's a reactionary leukocytic.
So what are your ventilated settings? Your ventilated setting at this point?
In the day 4 also it is around FiO2 was 0.6 and CP was 8, sir. And there was secretion in the ET2 in the ET2 also there was no copious secretion on this day. And so because he become irritable and this because of we thought maybe this is the possibility.
So did you start on any antibiotic? Any antibiotic now?
Sir, yes, sir. In this day we started our Magnexport, sir. Magnexport 1.5 BD we started on this day, sir, actually. Because we don't know because already patient on 4th day of ventilator, possibility of VAP, ventilator associated pneumonia is there. And so because they tend to have lots of secretions because of bronchuria. So
can you tell what is VAE?
Sir?
What is
Ventilatory associated
events? What is
ventilatory
it?
associated events.
You have any X-ray?
Sir, initial X-ray, sir.
No, next slide or something.
Sir, next slide.
Yeah,
we had a
please.
little bit.
Please show X-ray.
Can I just stop
Yes,
you?
yes, sir.
So,
Yes, sir.
so Dr. Venkata Ramana, now let's say that you restarted the atropine after 1.5 hours, and the same thing recurred. Heart rate went to 150, temperature went to 104. Okay. Is there any other drug that you can use other than glycopyrrolate, which will also help in the CNS? Has any other drug been tried? That's all. We may not use it regularly. Have you read about any other drugs being tried for organophosphorus?
Scopolamine.
Sorry?
Scopolamine.
Correct. Scopolamine and one more?
That's Hyderabad, I think. Sorry.
One more? Hyoscine.
Right.
Okay. So scopolamine and hyoscine have been tried when people were in patients who have severe atropine toxicity, and they need to use something that crosses the blood-brain barrier. Glycopyrrolate alone will not help. Okay. Okay, fine. Go on. Next.
And on day 6, we given a spontaneous breathing trial, sir. ABG revealed severe respiratory acidosis, pH of 7.24 and PCO to 106. And the patient became drowsy and arousable, obeying commands. And heart rate is around 62 beats per minute. And there is still lots of scraps bilaterally. And we are able to note proximal muscle weakness in all 4 limbs and unable to hold the neck. So, and next slide, please. Once. On evaluation, chest X-ray showed there are lots of bilateral infiltrates, and because on day
how did you diagnose? Sorry, doctor. You said in view of intermediate syndrome.
No, sir. Because it is a day 6, and after giving the spontaneous breathing trial, and he almost there were no cholinergic symptoms as of now. But in these patients, in day 2 to day 6. There are possibility of intermediate symptoms, maybe because that we suspected because we have started having no onset of muscle weakness in all the limbs, and spontaneous breathing trial failed. So with the type 2 respiratory failure, we thought maybe he went into intermediate symptoms.
So then why did you continue atropine infusion? If you had no cholinergic signs and you think it's intermediate syndrome, why did you continue atropine?
Is there any role?
That's the question. Is there any role for atropine in intermediate syndrome?
Sir, as of intermediate syndrome, there is no maybe atropine because we have to continue, sir. Maybe
you have to continue, is it?
Yes, sir. Because intermediate syndrome, they say it as such as because of atropine because of OP compound severity, or else because of inadequate dose of TAM, because of aging the possibility there. So, sir, I don't know.
Okay, you don't know.
But
okay, so let me ask you, in intermediate syndrome, you already said the muscle weaknesses were proximal, neck muscles and all that. What is this weakness due to? Is it an upper motor lesion or a lower motor lesion?
It is
first
more
tell
of
me that.
Lower motor.
If it is lower motor lesion, where is the issue? Is it in the muscles? Is it in
neuromuscular junction, sir? Neuromuscular
Are you
junction,
sure?
Sir.
Are you sure? What have studies shown?
Because there are 2 types of because in the day timing, sir, in day 2 to day first week of illness and after long term or chronic poisoning.
No, that's different. Long term, after 14 days, weakness is a well-known entity of polyneuropathy. OPC-induced polyneuropathy. Not that. I'm not talking about it. I'm talking specifically about weakness that happens in the 4th to 6th day of OPC, intermediate syndrome.
It is more of neuromuscular junction, sir.
Will you look it up? There is more and more evidence coming out saying that it could be a myopathy. Okay.
Okay, sir.
Okay, look it up. There is more evidence now coming up. So nobody knows. We we initially thought it was all because of the lack of acetylcholinesterase causing problem in the neuromuscular junction. But now what do you call it? Neuro studies.
Neuromuscular studies.
Neuromuscular studies are pointing that there could be a myopathy component to it. Okay. And atropine or PAM both don't help. It's just time.
treatment.
Okay, it's just time. You give time, and if they slowly come out of it. And if they do not, you said they do not have cholinergic signs. If they do not have cholinergic signs, maybe atropine is not the thing. But I'm surprised if you say there's no cholinergic signs, because a lot of our patients on the 6th day also will have a lot of cholinergic signs. Like, you are saying bilateral crepitation, all that. Still, maybe he still has
heart rate 62 per minute.
Yeah.
Crepitation, and chest X-ray showing bilateral. I think infiltrates, you will see what type of infiltrates are present.
Correct. Okay. Yeah. So this can be intermediate syndrome. I agree. Fine. Because you're coming up on the 6th day. Fine. Okay. Next. Okay.
On day 6 is the X-ray showing there is a bilateral fluffy shadows, and especially sparing the periphery. So possibility of pulmonary edema is there, sir, but his cardiac status is okay with EF of more than 50%, and conductivity is good. There were no reasonable abnormalities, and TLC were normal, and apart from after stopping atropine, temperature becoming normal. So there were no signs of infection as of now. So maybe we thought of more of after seeing X-ray, we thought maybe non-cardiac and pulmonary edema maybe be related to poisoning only, sir. So maybe this is a
you have started an antibiotic. If you have not started an antibiotic, if you believe in that, and then the fever has subsided, I agree. So what is VA is? Ventilator associated events. What is it? Dr. Sitha. So as soon as the patient comes to the intensive care unit, you have put on a PEEP of 100, FID of 1 and PEEP of 8 or 10 you have shown, and this patient has stabilized. So any patient coming to the emergency ICU, you increase your FiO2 requirements, and the PEEP requirements comes down in the next 48 hours or stabilizes. Okay, and it remains like that for the next day, and 4th day onwards, if your FiO2 requirement is increased by around 0.2%, or if your PEEP is increased by 3, then this comes under a ventilator associated condition. Okay, so this is called a ventilator associated condition. So in this ventilator associated condition, suppose this patient has an increased WBC or a decreased WBC, has an increased fever or a hypothermia, decreased fever. So these two things we call as a patient, we can tell as a infection related ventilator associated condition. Okay, so this infection related possibly. Okay, so next is, suppose this patient, if you have sent a culture and the culture is positive, okay, which we can cause is a possible VAP. So these are the most important terminologies. You have to remember, this is population number 2012 and 13. We have to calculate our ICU daily, one of the criteria where you have to put in the quality indicator in the ICU, because all shadows are not because of infection. You can put this in terms of a ventilator associated condition, or you can put as an IVAP or a passable VAP. You can put into this. So I suspect in this patient, VAP is a possibility in this patient. That's the reason why this patient is not having much secretions. Based on the day 6, you said that there are no much secretions, but the fever is high. They usually doesn't have a fever of Atropine 104, 104, and this patient is having infiltrates. Probably, if you see, the ventilator settings also might have gone up, and you have put on a trial, pressure support trial. I think TBs or pressure support trial you have given. He has failed this. That is possibility for neuromuscular weakness also, but I think this chest condition also is a possibility. Okay.
Yeah. Continue, Dr. Venkat.
Sir, on day 8 also there is failed spontaneous breathing trial. So we taken decision to go for tracheostomy, and we did it on 9th day. And the atropine infusion slowly weaned off from day 10, from 1.5 ml to 0.5 ml like that on day 11. And by day 12, chest X-ray showed improvement, and we are able to wean off from ventilator. And gradually we will bring him back to portable BiPAP, and atropine and infusion stop. And on day 14, we shifted him with intermittent BiPAP to the room, and almost 6 days he stayed in the ward, and he also weaned off from BiPAP also, and decannulated and discharged. This is the course of his patient in our hospital. And
so why do he require this BiPAP for this patient so many days? Reason?
Sir,
Weakness.
Weakness. Okay. So did you do any nerve conduction study in this patient?
Sir, we couldn't able to shift to there. That's why we didn't do actually.
So what was the PF ratio and ventilated settings?
Sir, it was almost 232, sir.
So just I want to know about whether there is a lung problem or a muscle problem. Okay. So that's the reason why I'm asking you. Because this also has a bilateral diffuse infiltrates are there. So how many days did you continue antibiotics?
So we continued almost 5 days of antibiotic given, sir. Magnus Fort on day 6 to day 11 was given, sir.
Okay, Babu sir, any questions?
No, nothing. I think we have, no, I have nothing from this slide. No. So if there is any other questions from the other participants, we can discuss that.
Yes. Please post your questions in the chat box. Any questions from Facebook, Dr. Shashidhar?
No, sir. Actually, I want to ask few questions, sir. What maximum dose of atropine we can use? Because here, majority of physicians, they will target only heart rate. Though the lungs are dry, they wanted a heart rate at least 100. So in that case, sometimes we are using atropine of almost 400 mg per hour like that. So that is leading to fluid overload. Daily we are giving some diuretic to counter that. So are there any studies or any maximum dose of atropine which we can accept and use?
0.02 to 0.98 mg per hour, sir. Maybe, but what they're saying is if hemodynamics blood pressure is okay, targeting only drying the lung is more important than targeting heart rate.
No, that we accept, but how to make the physicians or primary team
convinced? In one study I did, sorry, they mentioned like maybe they go up to maximum of 36 mg, sir.
36 mg.
So
because
how much mg you mentioned per hour?
400 mg, sir. Almost 400 ml, 400 ml, 500 ml also we are using for some.
So you are using that 1 ml, 1 mg per ml that infusion, 500 ml bottles.
1 mg per 1 ml, sir.
Yeah,
those bottles we are using. And we will be able to achieve the dryness maybe with 40-50 ml, but they wanted a heart rate at least 90 to 100.
I think I've not in the it's quite some time since I got organophosphorus, to tell you the truth. But last, I don't remember going up to that high, 400 milligram per hour. I don't remember doing that. I think it's just a matter of
I think Yeah, you need to check your storage things also, because 400 to 500 mg per hour I have never used. Atropine.
Yeah.
Very high.
I think other thing is to discuss with the with the primary physician to say that it's just a matter of convincing them that that high dose is not needed.
Yeah, so sometimes we are starting even adrenaline infusion to transiently increase the heart rate while coming down on the atropine, just to keep them happy.
Give them a yeah.
Another question, sir. Actually, tachyarrhythmias are known with this thing. Apart from Brady, so recently we saw two cases. Two cases we lost them. So one patient, a young patient, he had tachyarrhythmias and biventricular dysfunction with atropine on day 12. So this patient also day 12.
Okay.
That is one. And second patient, he had tachyarrhythmias, continuous SVTs and VTs on day 4.
This is post-atropine.
Post-atropine, and actually we first in case of first patient, we came down on atropine. Almost he was on intermittent atropine at that point of time. We have extubated and re-intubated that patient. So biventricular dysfunction we have seen for the first time actually.
Okay.
So that is one thing, and tachyarrhythmias also, ganglioside blocking effect that can lead to tachyarrhythmias, but continuous SVTs and VTs in case of another patient.
Okay.
So any experience, or both they consumed chlorpyrifos only.
Okay.
So that is it a known phenomena? Or?
No. I think it's just different people have different sort of cardiac sensitivity to the atropine that we are using. I think it's only that.
Yes. And another thing, sir, regarding feeds, actually, Srinivas started the discussion RT feeds. Because of atropine, patients will have paralytic ileus, and majority of patients we won't be able to achieve the caloric needs.
True.
So can we use prokinetic drugs in this while giving atropine? Giving prokinetic drugs like metoclopramide or erythromycin, is it suggested, or should we avoid them?
Again, I don't know whether anyone has even looked at it separately. Anything, Srinivas, you know of?
No, sir, I have not seen, but I think it can give, I think, or see, we no need to achieve the higher targets. You can feed with around 600 or 700 kilocalories or maximum 1000 kilocalories in this patient for a first 4 or 5 days, and I think after that the effects will go, and then he can tolerate higher speeds.
Yes. So some physicians are allowing, some are not allowing. Actually, we are using prokinetics. So far, we have not seen any adverse events. Only when I was doing my fellowship, maybe way back in 2012, one perforation happened actually when we used the prokinetic drugs. But apart from that, I never encountered any adverse event with the prokinetic drugs. So that is one thing. And another question which I want to ask you is how to prognosticate these patients, because they will tell they have consumed some 70 ml or 50 ml, but the requirement of atropine will be high. Is it the severity, and there is no marker available as majority of centers won't have any RBC cholesterol level monitoring and all. Only we have pseudocholesterol monitoring system, which anyway we have discussed that is not a sensitive thing. So how to prognosticate the families? Is it just based on the atropine requirement or severity, or
usually what I do is based on what type of pesticide they have taken. So what we have seen, if you look at the last Sri Lankan study which came out in 2009 or 10, that's the one that they compared the 3 groups, clearly showing that people who have taken WHO hazard group 1, majority die. 2, and when it comes to 3, the mortality proportionately comes down. So I think it depends on the toxicity, how much it has bound to the nerve, the cholinesterase, all that will decide more than the dose. I think dose of atropine is just indirect marker of the severity. More longer we use it, it's just telling us that the effect of the OPC is still persisting there. So I think it is the type of pesticide which will determine the outcome.
Also the presentation to the hospital, how it is present.
Correct.
I referred on Netscape. It's given a 1 point, sir. Whether how to relate, I don't know. He given like to prognosticate markers like lactate and lactate clearance and pH. These are the two markers. If unable to clear by 6 hours, lactate or increasing lactate more than 5 and lowering pH. These are the two markers have a high mortality of patients. I referred in Netscape. It's given like this. But I don't know what is the relevance to this.
Is it these two are not specific for organophosphorus? No, any condition where the lactate which is high and lactate clearance is not happening tells you the patient is dying. So yeah, so I don't know whether it's specific for OPC.
No, it's a general tissue marker.
Yeah.
Another question in the chat box, sir. Only one question which is little interesting. How long to continue PAM with the current evidence?
Okay. Very difficult to tell. First question is, should you use PAM? If you have used PAM, and then once you have started it, I don't think there is any point in continuing PAM for more than 48 hours. Because if you look at the aging of most of the OPCs, even the diethyl ones, where you can give, they're saying 36 hours. By 36 hours, 50% will get, then if you go beyond that, it comes to about 150 hours. So 48 to 72 hours, then come off it.
Okay. But sir, one line they mentioned, sir, on article, they take as long as we give atropine, like before stopping atropine 12 to 24 hours, then we have to till that date.
Correct. That is another school of thought.
Yeah, that is as per even WHO guidelines also recommends the same.
Correct. So see, the thing is, nobody knows. We don't have large studies and very clear evidence that PAM can cause harm. So keep that at the back of the mind. So the WHO clearly says as long as the patient requires atropine, continue PAM. Okay, but then nobody has studied it. So it's a double-edged sword. Go clinically.
Okay.
No, usually I use for 48 hours. And basically, because it also can harm.
Yeah. So you are trying to regenerate the acetylcholinesterase. Yeah. So if your drug is lipid soluble, and it is of diethyl, use it. But you do, I don't know whether there's a point in using it for 7 to 8 days. That's my only.
I think there are no more questions, sir. We will conclude the session. Thank you, Babu sir, and thank you, Srinivas sir, for sharing the knowledge with all the students all over the India. And thanks, Dr. Venkat and Dr. Sitha, for bringing a good case for discussion.
Thank you.
Thank you all.
Thank you very much.
Thank you so much, sir, for giving me this opportunity. Thank you.
Thanks. Thanks all.
Okay.